Yes, it's my pleasure. Thank you for having us. So good afternoon, everybody. Thank you for joining our Guardian Pharmacy FHCA educational webinar. Today we're going to be discussing the appropriate use of nebulizers and aerosolized medications during this COVID pandemic. We at Guardian are very proud to participate and work with, partner with FHCA to do some virtual meetings. As Tyler mentioned, we have some other virtual meetings as well. We also are partnered with a long-term care educational provider called the Association for Medication Education. That's AME. So you'll see some other invites from AME. We have a meeting in August that's going to be virtual. That's going to provide CE credits as well. So be looking out for that kind of stuff. And that's some of the reason why we wanted to capture everybody's email address that's on here, is to make sure that you don't miss out on any of the webinar opportunities. Our next webinar opportunity is tomorrow, as a matter of fact. So if you need your med errors, we're doing them same time again tomorrow. Obviously, med errors is a little bit longer of a presentation than what we're going to give today, but you can log in there. I would just ask, so Jill is our sales and marketing person. She is on now. Her email is jill.daly, D-A-L-Y, @guardianpharmacy.net. Just reach out to her and she can provide you with the details going for tomorrow. And then also make sure that you're included in all the invites as we do more of these throughout the course of the rest of the year. We are still new to this, at least a little bit, getting the hang of all these meetings. So we're happy to be in the virtual meeting movement here in 2020, and very, very thankful that you all attended. So as Tyler mentioned, my name is Alan Obringer. I'm the president and owner of Guardian Pharmacy of Orlando. I'm a pharmacist, a consultant pharmacist, and geriatric pharmacist here in Florida. I am joined today by Michael Samarkos. Michael is our regional director of clinical and consultant services. He's a pharmacist and a consultant pharmacist as well. He handles the Orlando area and also the Tampa area, providing consultant pharmacy services for the customers that we have in those vicinities. As I mentioned before, and as Tyler mentioned, make sure you use that chat feature to log in and grab that information, to put your license number and your email address in there. Jill is diligently working behind the scenes to make sure that we capture all of that stuff. And then as we go through the presentation, use that chat function to ask any questions that you may have. We're going to do our best to try to field some of those during the presentation. If we don't get to them during, there's a little bit of time at the end built in to make sure you get all your questions answered. So with that, I would say we'll go ahead and get started here. Easier said than done. There we go. So like many of you, when this COVID stuff all first started and the lockdown first began, we saw a very quick reaction to discontinue nebulizers. We were approached by all of the skilled customers that we have, for the most part, reaching out to say, hey, we got to get these nebulizers stopped. What can we change these patients over? What's going to be safer for the staff? What's going to be safer for the residents or roommates or whoever else? What we wanted to talk about today is, it may not feel that way. It certainly doesn't feel that way to us as the number of cases go up, but we've learned a lot. We've had a lot of experience. We've gained a lot of knowledge about COVID, about how it spread, about the risk to others. And what we really want to do is we want to make sure that we're doing right by our patients. We may have overreacted at the beginning. We may have underreacted at the beginning. That's really for you all to decide as we talk about today's subject matter. But we're going to present you with a bunch of studies, the information that we've learned, and really hopefully help you guys answer some questions about what's right for each individual patient. The example that we've used, and Michael and I have obviously had a number of discussions here, the closest example that we can use is if you all have been in practice here for a while, like we have. In the recent past, there was a huge issue with opioid abuse And the regulations really swung to making it incredibly difficult for patients to get those opioid medications. And we compare that to today. You know, we saw that pendulum swing at the beginning of the COVID to, hey, let's get rid of all the nebulizers. Well, much like with the opioid crisis, where we made it really difficult, especially in long-term care, we made it so hard for our long-term care patients to actually have access to those meds. We needed that pendulum to swing back, and hopefully it swung back to the point where there's access for those who need it, and we're still preventing abuse in the opioid case. And that's really what we're here to discuss today, is to make sure that those patients who have a great benefit for a nebulizer have access to it, and access to those medications. And again, those who are being handled properly with the use of handheld devices, we can keep them successfully treated as well. So with that, I'll pass over to Mike to start us off.
All right, good afternoon, everybody. So like Alan said, we've learned a lot really with COVID itself, as well as putting this presentation together. One of the first things, we all have heard the social distancing and stay 6 feet apart. And one of the things we have to look at is why that is. It's because of something called a droplet nuclei. Now, I don't think that's in everybody's vocabulary, but I did a little research and to put it into terms that at least I understand, which I don't know. I figure if it's that simple, then probably everyone else will understand it as well. Droplets, when we sneeze or cough, are all different sizes. That pretty much makes sense. The bigger the droplet, the shorter the distance that it is effectively carried away from us. The smaller the droplet, the longer the distance that is carried away from us. So if we look at that 6 foot span, which is about 2 meters, that encompasses, for the most part, droplet sizes of, say, 50 to 100 micrometers, which is still really small, but I guess in the world of droplets, they're heavier. So it makes sense that if someone is infected, whether it's with COVID or with the flu or some other respiratory infection, that staying out of the vicinity of those droplets getting on us or being able to be breathed in by us lowers our likelihood of being infected. So that's something we know. What we don't know with COVID is the infectiveness of what's called a droplet nucleus. So droplet nuclei are aerosolized particles that are so small that when you sneeze them out or cough them out, they actually evaporate in air, and leaving the material that's inside floating around, kind of like dust, except microscopic dust, that could possibly infect us. So part of the controversy and why the knee-jerk reaction kind of started with needing to curb the use of nebulizers is the controversy surrounding, are these droplet nuclei infectious with COVID-19? And two, are they generated by, we know they're generated by some procedures, as we'll see later, but are they generated by nebulizing procedures, which can cause risk, like Alan said, to both the providers and the people in a facility? So risks of exposure. So we're all falling into the new normal of being careful with our exposure risk to COVID-19. We know that COVID-19 is transmitted primarily via respiratory droplets. We know that some procedures may generate aerosols or respiratory droplets, and we'll go over those in a little bit. What we don't know is what we've already talked about, is the contribution of smaller respiratory particles to person-to-person infection. And what it looks like right now is it's not especially likely, and we'll get into some of the evidence as of why. Like we've touched on, COVID-19, the primary concern is the risk of infection with generation of aerosolized particles. And nebulizers fall into that category, kind of, but there again, with the evidence that I think that's out there now, it definitely bears bears further discussion. There is some proof under controlled environments that COVID-19 is infectious and is available as an aerosolized particle for a few hours in air. But there again, controlled environment versus, humidity or heat or cold or, the regular environment are two different things. So there's no actual proof that in an aerosolized form, it remains infectious. So in the beginning of our pandemic, ASCP came out with some guidelines regarding what to do with an infected patient. And of course, it's ASCP, so it's more concerning the older and long-term care or institutionalized patients. And what they said is once a resident has a suspected or confirmed COVID-19 infection, that their nebulizer therapy, if they're on it, should be converted to a metered dose inhaler if it's appropriate and available. And that's something that's important that we're going to touch back on later. And if therapy is required to be continued, that healthcare practitioners should utilize the highest level of personal protective equipment. So we always have to remember that way back when all this started, PPE was in short supply, to say the least. And so maybe that was the right choice to just discontinue therapy. What I saw in my practice is they discontinued everyone's therapy, whether you were infected or not, whether they even had a positive case in the facility or not. And, I think that was kind of a knee-jerk reaction at the time. With the evidence that we have now, I think we can all make better choices going forward.
As Mike mentioned, we know that there are some procedures out there that do increase risk of the healthcare workers, of anyone who's in the area. I don't think that there's anything on here that's all that surprising to us. If you have a patient who's being intubated or is being extubated, if you have someone who's on manual ventilation or getting a bronchoscopy done, or if you're doing any kind of sputum induction, you're forcing them to cough. We know that these procedures increase the risk of transmission. And again, by looking at the list, you can see that most of these are done in the hospital setting. And this is the one where the maximum, like Mike just talked about, the maximum amount of PPE is used when these have to be done. There are some other procedures that could possibly increase the risk of transmission, and you see that this is where nebulized treatments come in. The oscillatory ventilation or rescue ventilation is where we're pushing air into someone more rapidly, and again in a rescue setting. But the original thought is that there's some at least logic that could be applied that says that there's an increase of risk, but there's not a lot of proof that there actually is. And we're going to share some studies here in a minute to kind of show you what we're talking about there. And then, of course, with COVID-19, we now know that there are some procedures that are out there where there is no evidence of increased risk. And this really does matter to us because, again, this is a lot of the symptoms and things like that you see. If you compare COVID-19 to like Legionnaire's disease, toilet flushing can spread Legionnaire's disease for several feet, basically all around any kind of bathroom. Well, we know that with COVID, that's not true at all. There's no risk with toilet flushing. There's no risk with vomiting. So again, we now have enough information to know that there's zero evidence of these things causing any kind of problem or issue for ourselves or for our patients.
So CDC, of course, has their own stance on aerosol generating procedures in the area of COVID. And what they talk about as far as nebulizer administration, and when you go back and look at nebulizer administration being a possible contributor to aerosolized product, they say based on a limited available data, it's uncertain whether aerosols generated from some procedures may be infectious. So the CDC itself is already throwing out a little bit of doubt into this. Let's make sure we change everyone off of a nebulizer to something else. We do know that aerosols that are generated by nebulizers are usually the medication itself that's aerosolized and being pushed into the patient. It's not aerosol that's generated from the patient being expelled out. So that's another thing to think about. Does the nebulizer machine generate an aerosol? Yes, it does, but that machine itself is not the thing that's infected with COVID. So perhaps it's not generating an aerosol that is infectious. And since there's still uncertainty, and the CDC even states that there's still uncertainty between performing some procedures that may or may not generate aerosols and weighing that the risk versus benefit of performing or helping the patient with a procedure versus, you know, the risk of not helping them, we always have to remember to err on the side of what's the best thing for our patients. So there are some studies that they did that we can use for evidence today. So these studies are from the early 2000s with the original SARS outbreak. The original SARS from 2002-ish was also a coronavirus. So these coronaviruses, they're around. They're in many different forms. The one that's with us today, I'm sure will be followed at some point by another one at some point in the future that will also have similar characteristics to the ones that have come in the past. So what they did is they looked at patients with the original SARS that were using either a nebulizer or a humidifier, and then they tested the air in the room to see if they could find infectious particles. And in all of the patients that they tested, they couldn't find any infectious particles in any of the air samples from any of the patients. So that's something we can extrapolate forward, being that it's a similar type of virus, and use that evidence in our decisions today.
The question becomes, you know, where did the CDC and the World Health Organization get their recommendations? And obviously, we've all seen it on the news, and you know, we've seen our political figures and their varying opinions. But we wanted to make sure that we shared with you where they got this. So as Mike mentioned, you know, the original SARS outbreak is a very similar type of virus from the early 2000s. They did 3 studies with the risk of transmission through a nebulizer. 2 of those studies said that there was some risk associated, while the third one said that there was none. It was the opposite side of the scale. When they combined all 3 of those studies together, they really found that there's no statistically significant risk of spreading of the COVID virus to healthcare personnel caring for those patients. And you got to remember as well that throughout all of these, there was no PPE being used. So they're saying that, hey, there's no statistical evidence and there's very little evidence whatsoever that there's any kind of transmission. And add to that the fact that we weren't using PPE at the time, you know, that shows that with some safety precautions, it's going to go even lower. I don't want to belabor the point on this particular slide, but you can see here's the combination of those 3 studies. The odds ratio of 0.9, anything less than 1, is something that's unlikely to occur. So we talked about those known procedures before, and if you look up a couple of columns here and see that tracheal intubation, that odds ratio is 6.6, so meaning it's more than 6 times likely to cause or to increase risk of transmission than nebulizer, and obviously that the nebulizer itself is of no risk.
So back in California, or out in California in late February, we had patient 0, or the first community acquired COVID-19 case. So no one suspected this patient who was in the hospital for an extended period of time with pneumonia and, you know, fevers, etc., as having COVID-19. So when they went back and looked at the patient and the patient's care, the patient had multiple healthcare providers that were exposed without PPE and without, you know, the equipment that we're using today. And they looked at the infection rate of everyone who was exposed to this particular patient, and what they discovered is pretty interesting. So 43 of the 121 healthcare providers that were exposed to the patient developed symptoms. Now, we don't know if they were all positive. We do know that the testing in the beginning of the COVID outbreak, especially here in the US, was questionable at best. So we do know that 3 tested positive. So of those 3, they all had unprotected contact with no PPE. Yes, some of them were performing aerosol generating procedures, nebulizer treatments, BiPAPs, etc. And they were even with the patient for extended periods of time. So all of those things could have promoted to their infection. But what we don't know for any of these folks is, was it the procedure that they performed to help the patient, did that promote their infection? Or was it just being in close proximity to the patient? If you're in close proximity to someone who is ill for an extended period of time without any type of PPE, your likelihood of getting sick goes up. So, it gives us some good evidence. It gives us a lot to think about. Yes, it appears that 1/3 of the people that came in contact with the patient had some type of symptoms, but not everybody got sick for whatever reason, and no one was using any PPE. So it gives us good evidence, but what it doesn't help us with is, what are the positive effects of using the correct protective equipment, and does that make treating these patients a lot lower risk for the provider, as well as spreading any other disease? So what the CDC has also come up with is guidelines for the healthcare providers themselves. It's pretty much common practice anymore that everyone gowns up all the way with the N95 or higher level respirator, the gown, the face mask, the gloves, respirators if they're available, the whole 9 yards. The CDC has also recommended that the least amount of providers available to perform whatever procedure is necessary for the patient are in the room with the patient. And that's kind of common sense. So the least amount of people that are available is the least amount, the least chance of spreading infection. What the CDC does talk about, and it's something that may or may not come to pass later on, is the use of isolation rooms. Hospitals have isolation rooms. These rooms are negative pressure. So the idea is, instead of being either a positive pressure room would express air out of the room, a negative pressure only sucks things into the room and doesn't let things go out if the door is open or something like that. So if there is an infectious agent in the room, chances are it stays in the room and doesn't spread out the door and to other areas of the facility. And last but not least, we all had regular cleaning schedules before. The CDC recommends that we have more aggressive cleaning schedules, and especially after a known aerosol generating procedure, to be sure we get in and clean all surfaces immediately, if not sooner. I actually read that they approved Lysol as an agent to actually kill COVID-19. So Lysol or better as a cleaning agent, and be sure we hit all of our surfaces and keep the rooms as clean as possible.
There are other entities out there, obviously, besides just the one that we've included, that have provided some guidance, and we wanted to make sure that we shared that with you all as well. So in Minnesota, their Department of Health came out and said that if you have a suspected or a confirmed COVID-19 case, if the patient can tolerate it, we should switch to metered dose inhalers. They should have a dedicated spacer. Healthcare workers should obviously, as Mike just said, wear all of the eye protection, gloves, gowns, all that stuff during treatment of that particular patient, making sure that if they do have to stay on nebulizer, the patient's door is closed, that the healthcare worker maintains after setup of the nebulizer, moves away, 6 feet or greater to be as safe as possible. The Journal of Respiratory Medicine weighed in as well. They said that in mild patients with COVID-19 who are awake and able to, they should consider pressurized meter dose inhalers and dry powder inhalers as well as in place of nebulizers in this particular case. The one thing I want to make sure that we point out is that all of these recommendations have all come out and said, if the person is positive. If you have someone who's not positive and not suspected and has no symptoms, they're not addressed in this at all. They're good to remain on their nebulizer. It is really just if we have someone who has tested positive in these cases. The CHEST guidelines weighed in as well. And again, those interventions should be avoided when possible. Use meter dose inhalers. But again, that's if the patient, specific to if the patient has the COVID infection. We did want to make sure that we showed you the dissenting opinion, and that's from the National Institute of Health, so NIH in the UK. They basically said there's not a significant infection risk increase, so go ahead and keep using your nebulizer. So they've kind of taken the opposite route and said, listen, if that patient is on a nebulizer and they're on a nebulizer for a reason, leave them on that nebulizer so that they can continue to get the benefit. No need to change them over to those meter dose inhalers. What this has done is, because we, like Mike mentioned, the knee-jerk reaction, that pendulum swing to switching everyone off of nebulizers, it has created a shortage of certain meter dose inhalers in the country. And it started in April. It is still true today. As of this morning, it is still true. Things like albuterol inhalers are in shortage. They are tough to come by. They are still out there, but they've become, especially for us in our pharmacy, they've become difficult to source. We've had to get different kinds. We've had to get from different sources. And some of the reason is because this didn't just impact long-term care. This switch off of nebulizers was across the board. So if you had a patient that was at home and was using a nebulizer, a lot of the physicians were switching them onto a handheld device of some sort, and not really considering, well, if they're at home and if they live by themselves, who are they going to infect? Well, the answer is no one. They could stay on the nebulizer. If they're at home and they have a spouse, well, they're going to infect that spouse because of close contact way sooner than they would because of nebulizer use. So we switched all those at-home patients over to meter dose inhalers, and now we've created a situation where there's not enough of them. So it was officially listed as of April 8th as a shortage, and that shortage still continues today.
So there's a whole bunch of different medications in the arsenal for providers to treat COPD. There's a multitude of handheld devices. There's nebulizers. There's even different types of nebulizers, as we've discussed. There's long-acting medications. There's short-acting. There's rescue medications. What we do know is that all these medications, if they're used appropriately and the device or way they're administered to the patient notwithstanding, they deliver a similar efficacy and relief and treatment of a patient's COPD. So just a cross-section of some of the nebulizer devices that are available. We talked about there's different kinds. There's the standard nebulizer that we all know and love that is a nice big clunky machine. There's some smaller machines that are available. Some machines, I'll point out the two at the bottom of the page, the Aeroneb and the Lanhala Magnair, have really short treatment times. So some of the standard treatments, especially that you see in a long-term care facility, could involve nebulization for up to 15 minutes. Some of these other devices provide medication in as short as 2 to 3 minutes, or maybe up to 5 minutes. So what we have to think about is, do we automatically discontinue a nebulizer, especially a nebulizer that only takes a couple of minutes, maybe twice a day, to introduce a device that is shorter acting, that may require 4 or 5 or 6 administrations in a day? I mean, are we using more PPE for that administration, especially in a long-term care facility? Are we getting the same effectiveness for the resident? What's that? How is that resident affected? How is that healthcare provider affected? How's the person helping with the administration of the medication? How's their time affected? It all weighs in to not only the care of an infected COVID patient, but it can ripple over and affect the care of other patients as well. So similar to what we did with the nebulizer devices, there's a multitude of handheld devices. Again, here's just a cross section. Some are breath actuated, like the Seabreeze. Some are pressurized meter dose inhalers, like the albuterol. The other thing we have to think about is, if you've taken someone who has been on a nebulizer for quite some time and is used to using a particular device in a particular way, and now you hand them maybe 2 different handhelds, one long acting and one short acting, both of which work a different way, are we introducing the possibility of error on the part of either the patient administering it to themselves, or even the healthcare worker making an error in the administration of the medication to the patient? Or, as we'll see later, some of our long-term care patients may be cognitively impaired and don't understand something new. So are we making the best choice for them? It's stuff we need to think about. So there's pros and cons for everything. I'm a big fan of pro and con lists myself. Handheld devices have a couple of pros and a few cons. So they're easy to access, they're easy to carry around, and they're widely available. So for the people that use handheld devices successfully and that have COPD and that are out there living their lives, it helps them to be mobile and to be effective and to improve their quality of life. So especially as we get into an older population, there's quite a few cons with handheld devices that we can't overlook. We touched on it previously, which is each device works in a little different way. Some devices require certain techniques. Some devices require perhaps a pretty good inspiratory capacity. Some require coordination, and some require a certain level of physical dexterity. And if any of those things are missing, we are introducing the opportunity for a less effective therapy. So as we've touched on already, the technique varies depending on the device. So what we do know is more than 2/3 of patients that use a handheld device make at least one error while using the device. That's not real good statistics for making sure that we are getting the most effect out of our medications. I remember them teaching us in pharmacy school that medications work very well as long as you use them properly. And this is a startling example of medications not being used properly. And if they're not being used properly, especially when it comes to breathing, that's probably not the best choice. So in a study, they looked at COPD patients that are discharged from a hospital with handheld devices. And what you'll see here, if you look through the statistics, is pretty startling. So about 1 in 20 of the people discharged with a handheld device use it properly most of the time. That's not real good statistics for success. 1/4 of the people that are discharged with a handheld device use it regularly, but not properly most of the time. So again, maybe they're getting some help from it, but not the maximum effectiveness and control of their COPD. And then around 1/3 of the people charged handheld devices that have severe COPD didn't use their inhalers properly or regularly. And especially this day and age where we worry about readmissions in a long-term care facility or just in general, those statistics aren't real good, and an exacerbation can put someone back in the hospital pretty quickly. So they looked at the different styles of handheld devices and what patients liked and didn't like. So we touched on earlier, there's different types of inhalers, and it looks like the dry powder inhalers, which are breath actuated and don't require too much timing, are usually rated the easiest to use. And the pressurized meter dose inhalers, like the albuterols and unfortunately the rescue inhalers, are more difficult to use. And I can imagine if I was having a COPD exacerbation and I had a device that I wasn't confident with, or it was difficult for me to use, it would only make my exacerbation, at least my anxiety during the exacerbation, worse. So again, something to think about, especially if we're looking at making changes in folks that may not need it. And of course, there's disease-related factors in our elderly patients, whether it's just physical or cognitive decline, or it could be an active disease like Parkinson's that could make, say, using a handheld device or especially a pressurized meter dose inhaler more complicated. There's just the general reduction of inspiratory flow in some of our COPD patients. Around 20% of them just can't inhale deep enough to get some of the medications that are coming through these inhalers to where it needs to go in their lungs. So again, we have to look at the big picture when making decisions in caring for our COPD patients.
Michael did a good job of talking about, there are pros and cons to the handhelds, and by no means do we want to come away from this presentation saying, hey, there's not a place. I mean, we use those, we dispense those, we recommend handheld devices every single day of our practice. They are the right thing for a huge portion of our population, but that's a huge portion. That's not all, and that's really the gist of what we want to get to today, because that same pros and cons list for nebulizers, there are patients who will receive benefit from it, but there are others that just won't. So, the pros for the nebulizers being, as Mike mentioned, the challenge with coordination and the technique. Well, that's removed with the nebulizer. If you have someone who has poor inspiratory capacity, or they have cognitive impairment, or they're just very ill, a nebulizer becomes a very good choice. You can adjust doses, you can adjust concentrations. There's no breath holding that's necessary. With the handheld, you have to breathe it in and you have to hold your breath for some period of time for it to maximize its effectiveness. But there's a reason why we don't see people walking around in the street with nebulizers. The equipment is cumbersome. There can be an expense obviously associated with it. The medications used in nebulizers are more expensive. So not everything is sunshine and rainbows when it comes to nebulizers, but there's a section of our population that's really going to be able to do that. And we talked about the use of those nebulizers. Some of them are time consuming. Some of them are 15 minutes. They're the newer ones that have come out have lessened that time to help the nurse, to help the caregiver, but they can be time consuming. And then in the new normal that we talked about before, these days where everything has to be cleaned, the nebulizer has to be cleaned and has to be cleaned well. Obviously it's a pretty simple wipe down for the handhelds. There's pretty careful hygiene and maintenance cleaning that has to be done on a daily basis for the nebulizer that can also be time consuming as well. So the good news is that about a little less than half of our COPD patients have a nebulizer, so about 45%. And the even better news is that of those that have it, 67% are using it on a regular basis. And because there's really limited skill and technique that goes into this, that 67% who are using it on a regular basis are getting the full effect from those nebulizers. What this really does for us, for you all as administrators, for us as consultant pharmacists, and for all of our practitioners, is it really forces us to ask the question, what's the best choice for this individual patient? If you have a memory care patient who has limited mobility and limited function, a nebulizer is going to be a no-brainer. If you have someone who's highly functioning, who's still able to walk, then a handheld device is probably going to be a no-brainer. it's the middle population, which is a large section of what we deal with and what you all deal with on a daily basis in your facilities. That's where we have to say for each individual person, what's the risk versus the benefit of using a nebulizer or using a handheld device. This was actually addressed here recently. There was a letter to the editor of the Journal of the COPD Foundation, and the authors of that letter, what they basically said is what we hope that you get out of this, and that is that there's not a lot of evidence that there's a tremendous risk increase of nebulizer use. That it's not going to increase our risk of transmission of the coronavirus, and that we should really be adjusting our practices to say, okay, let's make nebulizers available for those who need them. But they also were quick to say the other side of that too is if you have someone who's successfully treated, don't change them over, don't mess with success, keep them on those therapies. And then obviously they also were sure to mention the fact that as we get more data and we're learning things every day, the next stage of coronavirus vaccine trial is supposed to have data released on Friday. We're going to learn more from that trial and what the data is that's released. As we obtain that new data, we need to be flexible enough to make those changes. And again, we talked at the beginning about the pendulum swing, how we swung to try to get rid of all of these things. What this letter addresses and what we're saying in this presentation is let's start analyzing and let's start using the information we have to swing that pendulum back and to make sure that those patients who need this nebulizer therapy, who are at low risk, who don't have the COVID-19, that they have access to all of that stuff.
So our focus of concern really for all of us here is older adults, and especially our population that is in the long-term care facilities. And when you look at nebulizers or in older adults, they're often preferred, especially in a nursing home or a facility, because a large percentage of the residents in those facilities have either physical or cognitive impairment. So there's a 2012 study. They looked at 27,000 plus residents with COPD, and of that 27,000, a large majority received at least one medication to treat COPD, and about almost half of that population had moderate or severe cognitive impairment. So if you think about the implications of just changing one thing, even if it's the delivery of a medication that is being administered to a patient, to someone with cognitive impairment, we all know that leads to the possibility of ineffective treatment, for sure. These are easier for patients to use than handheld devices because they only require normal tidal respiration. So we talked about some of those patients that have reduced inspiratory flow, and they just can't use a handheld device. Some of them, they can't coordinate the device. For the most part, especially in our long-term care patients, just holding a device in their mouth or putting on a mask and regular breathing is the best way for them to get medication to where it needs to go. The nebulizers that we use nowadays, they're all effective for maintenance dosing as well as exacerbations, and all classes of medications are available for COPD via nebulizer.
I don't want to belabor any of the points that we've made, and I think that this particular slide and this particular information is not news to anybody. Obviously, our patients that have COPD are at a much higher risk of acquiring a COVID infection, and if they do acquire a COVID infection, they have a much worse prognosis. What we're saying in here is that, hey, now is the time to start making those individualized decisions. We have a lot of tools out there. Mike just talked about how all of the medication classes are all available in both a handheld and in a nebulizer. So now's the time for us to be looking back at those patients, seeing if they're well controlled, and adjusting those folks that are not well controlled to put them either on the right device, put them onto a nebulizer or whatever the case may be, but do that on an individual basis. To do that effectively, we want to make sure that we're asking the right questions, right? So again, Mike just mentioned the 42% of patients in that giant study that were cognitively impaired. So is our patient physically or cognitively impaired? Would they benefit from nebulizer use? Are they well controlled? You know, now is a good opportunity for us to look and say, are they at really high risk for an exacerbation? Have they had one? Do they have the adequate inspiratory flow? So if we're putting them onto a dry powder inhaler, can they get that medication out of the inhaler so that it can be effective? If we think that a nebulizer is a possibility, the questions can't stop there. We need to make sure that, hey, there is adequate PPE available for anyone who's dealing with it. You know, like we said, there's low risk with no PPE. That risk goes down even further to hopefully as close to zero as we can get when you actually have adequate PPE and you're using it. And then what can we do as far as that patient being isolated? You know, Mike talked early on about negative pressure rooms and things like that, and it doesn't even really need to be that involved. It can be, can we make sure that when we do the nebulizer, the roommate's not in the room with them? Can we make sure that the nurse starts it, and instead of viewing it from in the room, maybe they step outside the room and view what's going on with that particular patient? Can we do some sort of isolation to help that process and make that even safer for everybody around us?
So the thing we've touched on already, and something to remember, especially when we're making changes or we're seeing changes made in our facilities, is that the current recommendations to discontinue nebulizers are directed to people that are actually COVID positive. And making changes or rocking the boat of patients that are not COVID positive, whether they're long-term or even a short-term patient. If you think about a patient that's maybe in your rehab that came in with a nebulizer that someone wants to change because of the perception of some guidelines that are out there, if that patient goes home in 2 weeks with handhelds that they don't know how to use correctly because they never have, because they were on a nebulizer before, it's an opportunity, you know, for an error. And that's something we need to think about in the big picture of all of us making recommendations and looking at changes for our patients. As we get to the end here, we really have to think about what is the new normal. We all know the new normal, at least for the time being and for the foreseeable future, is face masks, social distancing, making sure we clean our hands, whether with soap and water or hand sanitizer, making sure we're, you know, covering our coughs and our sneezes, and wearing masks and gloves and proper PPE when we're treating our patients. All those things that have kind of been discussed already. We have to remember that the new normal is there to reduce the spread of infection, and it's going to be there, you know, until hopefully one day this infection is either no longer with us or not an issue. But by adopting all these things, we are not only protecting ourselves, but we're protecting our other patients and residents.
And Michael, I would certainly add, as we discussed yesterday, I would add to the new normal the purchase of toilet paper by the caseloads, as that yeah. That appears to be something that we all now take part in. So as Mike mentioned, just to wrap up, you know, we talked about, we now know more about how COVID-19 is transmitted. Those procedures, those aerosolized generating procedures that we know to increase, that possibly increase, and that we know don't increase that. We also know, which we've known for a long time, there's a reason for nebulizers in use, particularly in our patient population. And that decision, whether or not that patient needs it, that falls on us. That falls on each individual patient and each individual practitioner to make the right decision for that particular patient, to say, hey, if we think that there is increased exposure risk, can we minimize that exposure risk? Can we put PPE in place? Can we put social distancing in place? Can we have the right procedures in order to do that? And by doing so, can we make sure that we have the right therapy for our patients to make them successful. And again, I think we mentioned it throughout. Our concerns are still the same. These are very high risk patients. They're at high risk to get COVID-19, but they're also just at high risk to have exacerbations of their condition, not related to anything else that's going on in the world. And that puts them high risk to go back to the hospital, which is something we're all looking to prevent. So now's the time for us to start going back, looking at these individual patients, seeing if we're being successful. If we're not being successful, making adjustments to those, to those therapies, to those regimens, and potentially the device that they're using. So we have been recording everybody's licenses from the chat feature. So I thank you all for that. Just scanning through the chat function here, I don't see any other questions that we haven't answered as of yet either, which is also good. I will remind you that that if you have questions, if you want a copy of the presentation, if you want more information about Guardian or anything else, please reach out to Jill. Again, her email address is jill.daly, D-A-L-Y, @guardianpharmacy.net. We're happy to share any other wisdoms. Be on the lookout both from Guardian and, as we mentioned earlier, from the Association of Medication Education for more virtual CE opportunities. We're going to try to do as many of these as we can. We know that it's hard for you all to gather this kind of information, so we want to try to make it available to you. So be on the lookout for those types of things. And like I said, we have a MedErs that's going to be at noontime tomorrow. So reach out to Jill if you are interested in that one. And as I say that, I just got one. Actually, just somebody else making sure that their numbers are in. So thank you very much. So with that, we will say thank you. We will actually, yeah. So thank you to the person who just reached out. We will send this to Tyler, and he can forward it out to everybody. The presentation out to everybody, and you're welcome to use it for your own resource. So Michael, thank you very much for your help today, and
thank you guys very much for attending. We appreciate the opportunity.
Hey, Alan, it's Tyler again. I just wanted to say thank you for the presentation and putting this on for us. And I appreciate everybody got on the call. I think we got up to, 22 participants, so kind of exceeded what we were thinking. And I think that's pretty good given how crazy everything is, everybody's schedules right now. I just want to remind everybody that we're going to continue to hopefully do these on a monthly basis around the same time. Be on the lookout for the information regarding the dates of the Florida Healthcare virtual conference. I believe it's like the 6th to the 8th, but I know everybody's probably got that communication. And I just want to leave you with, if there's anybody that wants to get involved with the district, please shoot me an email. I've got to get back to Florida Healthcare for officers here in the next week or so. But outside of that, again, I appreciate everybody getting on, and hopefully this will be a good resource for us moving forward.
Have a good afternoon, everybody. Stay safe and stay healthy.
Yeah, thank you.